You know, no matter what profession you're in, there's always this high, hard ground overlooking a swamp. And up on the high ground, practitioners can make effective use of really well-defined theory and techniques, but it's down in the messy and uncertain swampy lowlands where you get the issues of greatest human concern. So tonight I just wanted to welcome you to my swamp of general practice. Now, I've talked about the GP swamp for years, but the idea isn't mine. It was developed by an architect, actually, Donald Schon. And tonight I wanted to have a look at the evidence for swamp medicine, the narratives that Canberrans hear about it, and the way that policies are influenced by it. I'll be focusing on mental health because we have such good data around our collective performance through the National Survey of Mental Health and Wellbeing. So, let's see what we do. On the left, you've got ACT GP activity, and on the right, national. You can see that orange curve there, seeing more patients with mental health conditions than any other services, and in fact, of all the services combined. Remember hearing in the media that we GPs disappeared in the pandemic? Not so. That blip around the pandemic years was us keeping patients out of hospital. There's a similar blip with chronic disease, elective surgery and domestic violence, all conditions that the hospitals had to turn away. Hospitals had the infrastructure and the equipment that wasn't available to us, but we had the relationships to manage the long-term patients who couldn't get timely hospital care. It really was a win-win. We also spent a couple of hours a day explaining vaccines, and we actually vaccinated 90% of Canberra. So the rhetoric that we were all at home with our feet up was deeply unfair and pretty inaccurate. We're also not bad at what we do, and I wanted to have a bit of a look at communication skills. The National Mental Health Survey tells us that we often or always listen carefully and show respect whether our patients are rich or poor, urban or rural. Over 90% patient satisfaction is a pretty good figure to attain, and we're proud of it. But just for comparison, let's look at how GPs compared with nurses, who are usually the ones to be seen as the most caring and compassionate of the health professionals. Compared to nurses, we actually do pretty well, with pretty similar scores. Except for country nurses who are exceptionally awesome, but that's fine. Mostly, we GPs are up there with them. It's a slightly different story with doctors. And I do wonder whether the ED scores are more about the context than the actual people doing the health professional jobs. But either way, GPs outperform most doctors on this metric. We're good communicators, and our patients value what we do. And we don't just do a lot of mental health work, we are really, really cheap. So in this graph, the red bar here shows the number of patients that we see in a year on the left, and the pile of coins as shown on the right axis shows the cost. Compared to other health professionals, we see an awful lot of people for very little cost. And you know, I think of this graph every time a psychiatrist or a psychologist publishes an article suggesting I modify my practice to echo their evidence and their perspectives. Our mental health workers are not the experts in the patients that they will never see. Our average out-of-pocket expenses are pretty good too, and they're less than any other mental health professional, at $10 per service on average. And if we look at how much patients pay over a year, mental health patients pay about $16 per year on average to see their GPs. So, we're cheap, we're effective, and we're available. But I hear you say not all GPs are the same, and I thought I might have a look at lady doctors. Whatever your profession, it doesn't matter whether you're a doctor or a dentist or even a vet, there are assumptions made about female health professionals. Lady doctors are supposed to be kinder, more empathic, and more self-sacrificial. People who've experienced trauma will often choose women GPs because they make these assumptions. They're also more likely to ask us to bulk bill. Remember that these assumptions aren't made by us, they're made by the community. And people choose lady doctors because they believe that these assumptions are true. And it wouldn't be a problem if women doctors weren't discriminated against in public policy. Now, women's work has always been seen as less complex and less worthy of support than it actually is, but general practice is no different. It's the complex, undervalued work that most women GPs do. We do longer consultations, seen here in the pale green. And this matters only because of the way Medicare is structured. My Medicare has only made this worse. So let's have a look at My Medicare. Stay with me here, I know it's a complex graph. So here's the hourly rebate for GPs who bulk bill 10-minute consultations. Now the urban ones are the blue and the grey before and after My Medicare. And then I've chosen remote practice because they have a higher rebate, and that's the orange and the yellow. And you can see that remote practitioners get a higher rebate than urban, which in my opinion is fair enough. So you can see that My Medicare has made a big difference to GPs who do 10-minute consultations. If you do longer consultations, the difference is much less. So you can see here that if I was spending 40 minutes doing a standard physical consultation, these are the rebates per hour. So we've made that work over an hour. However, it's a really different story. Despite the fact we know we get better outcomes for longer consultations, there are also Medicare disincentives to treat women. The hourly rate is much worse in mental health and antenatal care, and both were excluded from the My Medicare initiative. It does explain the truly appalling gender pay gap in general practice. On ATO figures for average taxable income, female GPs take about a 40% pay cut for doing some of the most complicated work in the system. The green column represents the total yearly gap, and the yellow the gap in hourly rates. Not just that, but our profession donates about $1 billion per year in unpaid labour, which funds about a half of the yearly non-GP specialist budget, or a third of the recent federal subsidy to the Pharmacy Guild. This is because Medicare's decreed that the only work it will subsidise is the work done with the patient in the room, which means low-value red tape, data collection, and all sorts of coordinating jobs are not funded, and they take up an average of 8 hours a week of clinical capacity per GP. Frankly, our goodwill budget is in deficit. And we're also experiencing increasing occupational harms. Now, this is the AHPRA Junior Doctor Survey showing that we continue to have an issue with bullying, discrimination, harassment and racism in our healthcare system. ACT is doing better than it was, and we're now roughly equivalent to the national average. Now, the bullying and harassment is usually thought to be mostly caused by senior doctors, and certainly a large proportion is a problem within the medical team. However, if you have a look at the next graph, this dark green bar are nurses. In the ACT, as you can see, GP trainees are twice as likely to be bullied or harassed by nurses than their colleagues in other states. But this is the most interesting graph here, I think. This is the bullying, discrimination and harassment from patients and their carers, which is extremely high, and we seem to have a situation where the ACT environment is quite hostile to GPs. So despite the value that we provide, GPs are becoming an endangered species. This graph shows the percentage of male GPs planning to retire in the next 3 years nationally, and the ACT figures are pretty similar to the national, but it's not the same for women. There's something about the ACT ecosystem that makes it challenging for female GPs to thrive. And I wanted to think about why it is that female ACT GPs are retiring so much quicker than female GPs elsewhere and their male colleagues. What is it about the ACT swamp that makes us want to leave? Well, let's have a look at some of the narratives that they're hearing. What we know from the evidence is that GPs are producing good outcomes, that patients are satisfied with their care, that they're cost effective, they provide equitable care, and they've compassionately billed for years. So, does the discourse around general practice match this evidence? Now, there's a lot of people around who don't appreciate the GP's role in the swamp and don't particularly like us. Like the blobfish, we work in the sludge of the system managing what the biologists call ocean dandruff, the stuff that no one else wants. If we want to continue to see, as a community, our hospitals in terms of economic growth, efficiency and productivity, then hospitals must continue to reject, eject or discharge patients who are too diverse to meet their stringent intake criteria. And they need to eject them as early as possible. Which means that GPs need to absorb the trauma, pain and suffering rapid throughput hospitals now excrete, which is partly why we're starting to drown. In addition, we now have to contend with the parts of the swamp that have been reclaimed and turned into specialised primary care units. Many of these act like gated communities, draining resources from the more lucrative parts of the swamp and making the remaining habitat deeper and less easy to navigate. This is the Origin building, which was recently built in Melbourne, so this is Headspace's research arm, that cost $60 million of taxpayer money and would have funded 110 full-time GP years. Gated community. Blobfish aren't seen very often and we're even more rarely valued. And one of the ways we know how we're valued is the discourse that's communicated to the public. So in 2023, World Pharmacist Day was celebrated with multiple ministerial videos highlighting the critical role that pharmacists play in our community. There was an equally significant shout out to nurses. But on World Family Doctors Day, there was conspicuous silence. But thanks, Mel, for this year, because Mel's comment was the only one we had. It's not about us, it's that every moment like this is a chance to build trust in the health system. But in our case, general practice remains pretty invisible. It wouldn't matter so much if we weren't inundated with such a negative view of GPs in the national press, where we're usually portrayed as fat cat opportunists feeding off the misery of the masses or deeply incompetent 1950s male relics who refuse to take their patients seriously. Now, I've had a career teaching and learning with nurses, midwives, psychologists, psychiatrists, carers, consumers and Aboriginal cultural educators and mentors, and I've been assessed by all of them. I enjoy interprofessional learning. But I have difficulty committing to collaborative learning when the Pharmacy Guild decides to tell me that it's bloody insulting to imagine pharmacists can learn anything from someone like me. Or the nurse practitioner lead who said that a collaborative arrangement between doctors and nurses is like domestic violence. I'm a qualitative researcher, so I decided I'd look a little more closely at what the discourse looks like in the ACT and where these attitudes actually come from. So I gathered together 12 months of ACT health communications. Your social media, your ministerial media releases, documents, Canberra Times articles, and as much as I could extract from the ACT health website, including reports. And that's about 430,000 words. I know you can't do it over the internet. I extracted anything said about nurses, midwives, pharmacists and GPs and looked for descriptive words. And here's what I found. Positive comments are in green, neutral in orange or black, and negative in red. So here's how nurses and midwives are portrayed. They're kind, compassionate, competent, with one tiny little oversight incompetence mentioned in the disability health strategy. All-round awesomeness, very trustworthy profession, which in my view is fair enough. The marketing of pharmacy is pretty clear. They had the same number of mentions as nurses, about 400, but a much more consistent comms strategy, all of which worked to build trust in their expanded scope of practice in the ACT. We, however, were not so lucky. No one in their right mind would see a GP on the basis of this evaluation of our competency, capacity and ethics. No wonder occupational violence is rising in our practices and there's an increase in ED presentations. We blobfish don't particularly care what you think of us, but we are restricted in our capacity to contribute to the health system if public trust in us is consistently undermined. I know that systemic bias is usually unconscious, but that doesn't make it right. So we have a yawning gap now between the evidence and the discourse. At the same time, we're losing our autonomy and agency, mostly through the twin crocodiles of paperwork and politics. The crocodiles harm us and our patients, and dodging them is consuming enormous amounts of energy and thought. If we could reduce the environmental impact of dropping crocodiles on our heads, we could get better value out of our general practice workforce. One crocodile breed that is particularly harmful stems from that discourse that GPs need to be nudged, hence the crocodiles, towards evidence. This is a well-meaning attempt to drive best practice, but the problem is often that the evidence is generated on the high ground, not in the swamp. We know that evidence is biased towards a population that looks like Norm here, male, white, privileged and with a single disease. Norm's evidence may well be a terrible choice for Maria. She was never in the trials. One of the weird things about general practice is this. It's the primary care paradox. We don't do as well as non-GP specialists in managing individual diseases and meeting individual targets. However, we get much better outcomes for the patient, the system, and the budget. And isn't that the point? If you force us to follow an algorithm, our outcomes will be worse, because standardising care to make better health for Norm is a terrible practice for Maria. I know it's frustrating, but if you allow us to think and not blindly follow an algorithm, we actually do better for our patients and for the system. So I think of it like this. Let's say there's some excellent research performed on the high ground of St Elsewhere's that will revolutionise how patients travel through the system. The team produced co-designed, patient-centred, evidence-based, innovative, technology-enabled scooters that will move patients efficiently and effectively through the system. The result of this sort of research will often include dropping those research products on our GP swamp with the narrative that they're evidence-based solutions. If they don't work in our context, the problem is often cast as our reluctance or incompetence. And the solution is usually either incentives or education to nudge GPs who are well placed to adhere to best practice. I'm telling you, GPs will not use scooters if the patients need rafts. We will dump the scooters, move around the scooters, or at worst, reconstruct the things until we make them work. We are pretty resilient. We can stand the vicarious trauma of deep and painful patient experience, but we cannot cope with the moral distress of standing by and watching our patients drown. Give us nothing but scooters and we'll turn them into rafts, which is what we call vicarious resistance. It's when trauma-informed care clashes with neoliberal bureaucracy, and we will always ally with the patients. We won't tolerate them being eaten by crocodiles. Now, we've all worked in hospitals, but very few hospital staff have ever worked with us because we see the patients who don't fit anywhere else. Our patients are really diverse. Our work is really diverse. And frankly, if it was easy to describe what we do, it wouldn't take more than a decade to learn how to do it. So I thought it might be helpful to give you a snapshot of our world to take away with you. This is my book of writing, which I've done for the last 5 years, and I've thrown together into an ebook. Young GPs have felt that they're failing, when in reality they're facing a system where it's incredibly difficult for them to thrive. I felt it was really important in the last decade for me to write and to help them understand what was going on around them. They felt so defeated and it just wasn't right. So I hope this book will give you a little bit of insight into what we do and why we do it. Because at the end of the day, the leaders in the room, this is the standard that you're walking past. And we GPs, we need to know whether you find this acceptable, because we can't contribute to the health system if this is what Canberrans think we are.